Thank you very, very much, Marco and Stephanie and Henrietta. Thank you very much for the invitation, and I must say that it feels quite daunting to be in this magnificent arena. It does remind me of the Montreal Neurological Hospital, also because when you enter there are halls that look similar to this. Somehow you're at the bottom and you know that the great ones are on the top, like Wilder Penfield and Rasmussen, so it has the same flair. So it's an honor to be here. I thought today we would talk about, now Marco asked me whether I was going to have a lot of anatomy. Well, I guess I have to say that it's indirect anatomy, but nevertheless, I'll try and make it as anatomical as I can. So we are going to be talking about the hippocampus quite a lot. And given the fact that we're working with children predominantly, it's interesting to know how this ability that we have, which is to do mental time travel, actually develops in children, particularly if they do not have as much of the hippocampal system intact as most of us do. So with that, I'll go on to the title of the talk. The subtitle of it, of course, is Developmental Amnesia, which is what I'm going to be talking about. Amnesia that actually starts before the memory system has developed. So the history for this, at least in our hands, started back in 1997 when we reported 3 cases who had suffered bilateral hippocampal pathology of early onset. And we documented that these 3 cases had a very severe impairment in episodic or event memory, but they had relative preservation of semantic memory or factual memory. And there would have been a lot of sort of speculation as to how this kind of a dissociation could actually emerge in a young person. And for many years since 1997, there were people who really doubted that this was actually a real phenomenon. To just give you a feeling of how these children present, when they first came to the clinic with the complaint that there was a memory problem, that they didn't quite understand how it came about, the parents would say that the children are always living in the present, they're not bothered about the past, and they don't have any thoughts about the future. But as a result of being like this, they're actually extremely easy to live with because they're not very demanding. And as those of you who may have children, you know that children can be very annoying because they're very persistent. They would not, if they want something, they will just keep at it until they get it. But these children are not like that, and it's their memory that fails them so that they do not actually insist on anything. That's why they're so easy to live with. The teachers usually say that they're very friendly and polite, but they're just too laid back, lazy and absent-minded. They seem to be very able because they speak very well, they seem to be very intelligent, but when it comes to delivering, they're unable to do so. And the patients themselves, they say that they listened in class and they understood everything that was being said, but a moment later it was all gone. So this is the typical presentation from kind of the layman's point of view and also from the patient's point of view. But when we started studying them, we realized that there really was a dissociation, and it showed itself at several levels. So the pattern of weaknesses and strengths that these children showed were that they were impaired at the surface level. They were impaired in event memory. They were also impaired in the ability to be able to recall, which is obviously requiring this mental time travel. And they were also unable to recollect the experiences of the past, bring it back to mind. On the strength side, they had very good factual memory. They had good recognition, so they knew that they had seen something before if it was actually presented to them again in a forced choice recognition paradigm. And they always had a good sense of familiarity. They knew that something was familiar, but they couldn't recollect it. And the neural substrate for this, for the weaknesses, it was a very marked but selective bilateral hippocampal atrophy. And on the strength side, we couldn't find any evidence of parahippocampal cortex damage, which led us to propose that those aspects that subserve the strengths, namely factual memory, recognition memory, and this preserved sense of familiarity, was dependent on the integrity of the parahippocampal cortex. So the first study that we did was to try and find out whether this bilateral hippocampal pathology that they had all suffered was showing its effect differentially depending on what the age of onset of pathology was, whether it had been in infancy before the memory system had developed at all, or whether it was related to later ages of acquisition of injury, which had enabled some degree of memory ability to be built up before the injury had occurred. So the supposition was that if it had been in infancy, there would have been greater plasticity and they would have been able to overcome the consequences of bilateral hippocampal damage better than if it had been later. So they would have approximated the adult amnesic patients a little bit more. Just to give you an idea of the kind of damage that had been associated with their hippocampal atrophy, many of them, the incidents had happened at birth. So either at birth or shortly after. But they all involved a period of lack of oxygen to the brain. So as you can see, it's all in yellow. Birth asphyxia. Whether it was associated with epilepsy or not was not the critical factor. The important factor was that there was a period of lack of oxygen to the brain. And obviously it occurs in association with a lot of etiological conditions. So the etiology was varied, but what was common was the asphyxia. And in terms of the late damage group, again, the etiology is varied, but that too had the common feature of asphyxia or hypoxia in association with cardiac arrest, respiratory failure, etc. So this just gives you a feeling of the etiological background of the children that we studied first in these two groups of early versus late. The presentation was that their brains are looking very much intact, but obviously the structural damage is visible, and you can see that in the case of John, a patient that we have studied. John has become very well known in the literature because he's got 19 papers to his name. So we've done 19 different types of case studies of him, and he's become very sophisticated. So sometimes he says to us, actually, if you did this, I don't think I would be able to handle it. So he knows himself what his failures are. So you can see he's lost 50% of his hippocampi bilaterally, but the rest of his brain is actually normal. But we wanted to be able to measure the degree of hippocampal pathology so that we could tell what level of atrophy is present in those cases that present with this profile that I've just pointed out. So the white bar above is obviously the range of normal volumes of the hippocampi, and these are the left and the right hippocampi of the early group, and here there are only 4 of the 5 late patients, and one of them had a defibrillator inserted into his heart, so we couldn't put him into the scanner, and this case was herpes encephalitis, and he subsequently underwent a left temporal lobectomy. But basically, these are the hippocampal volumes of the patients, and you can see that it doesn't really matter whether it's early or late because they have suffered the same degree of hippocampal volume loss. We next wanted to have a look at their everyday episodic memory function, and this was captured by this test of River-Mead behavioral memory test, which asks for a number of actions or a number of things to be remembered, name of a person, a belonging that you take away, a route that they have to remember, recalling stories, etc. In other words, a lot of activities that we do every day without even thinking about it, and we're able to perform. And here are the scores of the early group and the late group, and as you can see, it doesn't really matter whether it's early or late because the normal performance is here and they are significantly impaired. In fact, when you fall into this range, then you really are amnesic with regards to your episodic memory function. But when it comes to semantic memory, which is the areas that they're doing well in, it is actually interesting to see that, for example, their comprehension, the amount of knowledge that they have gained, or the vocabulary status is within the normal range, except here, the late group obviously is not acquiring as much information as they should be, but they are still, these are scale scores, but they're not really, with regards to the early group, they're certainly well within the normal range. But it is interesting that they are able to remember these decontextualized information so well, but they cannot remember these individual incidents that occur. And of course, you need both in order to be able to conduct your daily life. You can't do without one of them, one component being absent. So we were really, we still don't understand how they do it, quite honestly. But it does appear as though, because of course, whether it's semantic memory or episodic memory, there's learning involved, particularly with semantic memory, because you're always learning new information. So we don't quite understand how they do it. Because, for example, in the case of John, who was performing this vocabulary test at the age of 22 and then at the age of 33, he clearly learns information. Slow as he does, but nevertheless, he is able to learn this type of information very well, because at the age of 22, he didn't really know what the definition of designate was, but at the age of 33, he's got it. And same with plagiarize. Here, for information, he certainly didn't know the answer to these questions at the age of 22, but he got them right at the age of 33. So we don't exactly know how this happens, because we have tried to track it in the laboratory condition, and they are abysmal at their semantic memory in a structured situation. But when you actually look at them within the routine of daily life, you see that after a long time, they are actually able to learn. So it's a puzzle to us as to how they do it. But, and of course, it's this ability that then ends up enabling them to be able to perform like normal in terms of their academic attainments. And that's why the teachers are so puzzled as to why it is that they are appearing so normal and yet they are failing. Because their academic attainments, they all go to normal schools and they are able to, they're not brilliant students, but they certainly are able to maintain their standards in mainstream education. So the conclusions that we came to on the basis of this first study is that both patient groups have similar neuropsychological and neuropathological profiles. And this suggested to us that if this particular form of memory disorder is a special syndrome that's related to the early occurrence of this hypoxic ischemic damage, then the effective age at which the effects of it will be showing is from birth all the way up to pre-puberty, because we haven't seen anybody else really after that. After that, they become pretty much like adult amnesic patients. So, but this sequence that I have just described to you really happened in a way that was post hoc, because the patients first presented to us in a clinical setting. Then we found out that it was related to their hippocampal injury. And then we found out that they had actually had, at a certain stage in their development, a hypoxic ischemic event. So it was post hoc reasoning that led to putting the bits of the puzzle together. And even though it's quite convincing, because we have never seen anybody with that degree of hippocampal atrophy who is not amnesic, but nevertheless, it would be that much more convincing if we were able to do this in a predictive way. We would be able to go from hypoxia ischemia to hippocampal atrophy to developmental amnesia. And of course, in order to be able to do that, you really have to be there from the beginning when it actually occurs. So this is what we tried to do. We tried to actually do a study, which was the program grant that we had from the Medical Research Council, that enabled us to look at the effects of hypoxic ischemic injury on development of hippocampal function. So the hypothesis that we had, which is of course based in the literature, is that the hippocampus is vulnerable to hypoxic ischemic injury in the neonatal period. Actually, it's vulnerable at any period in life, but generally speaking, in neonatal period in particular, and that hippocampal atrophy we know is correlated with memory deficits. So if the hippocampal damage that occurs during the neonatal life is of sufficient severity, then it will result in this selective type of memory problem that I have just described, but it will spare the other aspects of cognitive function. Now, it is interesting because hypoxia is obviously a whole brain phenomenon. It's not related to the one region or another. The whole brain becomes affected by it. So it is kind of surprising that the hippocampus takes the first hit as much as it does. And the fact that they obviously don't have any neurological signs. None of the children have got motor disorders. So they don't have cerebral palsy. They don't have any other kind of deficits neurologically. So there are many etiological conditions that can do this, and we couldn't do all of them, but we started with at least 3 populations that we thought would be exposed to hypoxic ischemic injury, or they were definitely exposed to it, and some of them would be at risk of hippocampal pathology. The first group was the cardiorespiratory failure that was treated with ECMO. This is extracorporeal membrane oxygenation. The second group was the cyanotic heart disease. These babies were blue until they received their heart surgery, open heart surgery, during the first few days of life. And the third group is the extremely premature birth group, which is obviously susceptible to hypoxic injury because of lung prematurity. So just to give you an idea of the kind of conditions that they had, this is the transposition of the great arteries, where the circulation system, because of the abnormality in the heart, is disrupted, and the blue blood does not get oxygenated. And as I mentioned, the babies are blue until they are actually their transposition is corrected. So a certain cohort with this kind of pathology was cardiac abnormality was selected, and then they were tested when they were older, between the ages of 8 and 16. And then we had this group with the hemorrhagic lesions of prematurity. Even though these are not really centered on the hippocampus, but we knew that they were hypoxic related. And this is another kind of prematurity lesion, prematurity-associated lesions, the ischemic inflammatory lesions that are characteristic of prematurity. And finally, this group with the extracorporeal membrane oxygenation, which was in order to give the intensivist time to treat the cardiac and respiratory problems that they had. So you can see this tiny little baby over here, and all of this to provide them with time in order to treat the condition that they had. So these were the 3 cohorts that we selected. So we knew that they were all hypoxic ischemic at some stage, and when they were tested at between the ages of 8 and 16, these are the measures of the hippocampus and the global brain volumes that we obtained here from the cardiorespiratory disease cohort, the acute cardiorespiratory disease cohort. So you can see here the 0 line is the normal controls. This is the left hippocampus, right hippocampus, and the mean hippocampal volumes. These are other brain volumes that we got: gray matter volumes, white matter volumes, and the CSF. And of course, the CSF volume is increased significantly, and that's understandable in this particular cohort, and that's associated with the treatment that they received, the ECMO treatment that they received. And they do have white matter abnormality, but really the most sort of profound abnormality is in terms of the reduction of the hippocampal volumes, which is bilateral in the case of this particular cohort. And the same pattern, but to a lesser extent, was seen in the other 2 cohorts as well. So here we were trying to really demonstrate the causal effect of hypoxia ischemia. So when we correlated that with the mean hippocampal volume, and memory and intelligence, as shown in these two slides. We can see that the mean hippocampal volumes are shown here, and this is the mean delayed recall, which is a very sensitive measure of hippocampal dependent memory. And as you can see here, there's a significant correlation here. But when you look at hippocampal volumes in relation to full-scale IQ, for example, there is no correlation there, suggesting that this relationship is specific to memory and the hippocampus. And this is just another example of another component that is memory-related, which is related to the hippocampal function. So when we put all of this together, in terms of the incidence of memory impairment in the cohorts that we studied, the group that actually had the most is the cardiorespiratory failure group. There were 41 of them, and 18 of them actually were memory impaired. The criteria for classification of who was memory impaired and who was not memory impaired was that they had a significant reduction in their memory quotient in relation to their IQ. So you predict, given a certain level of IQ, you predict what the memory quotient will be, and if that memory, the discrepancy between those two was significant, then that actually counted them as being memory impaired. So there were 18 that were memory impaired, 23 that were actually normal in that respect. And this is quite a puzzle in itself, because the degree of hypoxia did not vary. The whole group had it. It was all the medical measures that we had available to us showed that this distinction between 18 and 23 could not be differentiated along any of the medical variables. But nevertheless, in 18 cases, the hippocampi succumbed to the effects of the hypoxia, whereas in the other 23 it did not. And similarly, in the cyanotic heart disease group, you have 12 who had this significant discrepancy between their memory and their intelligence, and the 29 who did not. And the least was, in terms of the extremely premature birth cohort, where only 7 in relation to the 34 had that kind of an impairment. So this is actually becoming an interesting puzzle, and we're trying to do two things. One of them is to try and see if this type of damage can actually be prevented. And that's the new program grant that we're working on, which is with neonates now, trying to do tissue preconditioning in order to protect the brain from this type of a pathology occurring. But it also raises the possibility that perhaps there are genetic protection factors against hypoxia ischemia that have not yet been discovered, and that those who were protected were enjoying the benefits of having that kind of protection from a genetic point of view, and those who did not have it. So that's another thing that we're actually working on now. But in terms of, if you compare then the two groups, then you will see that the memory, you will see that the memory impairment is actually very much there. This is now looking at the whole cohort, the 3 cohorts put together. So there were 123 of them or something like that, and 86 of them were memory unimpaired, and 37 of them were memory impaired, shown in the red columns. And you can see that all of these measures that are hippocampal dependent are showing the significant reduction of the memory impaired group in relation to the memory unimpaired group. And in terms of their preserved function, they're not significantly different from each other. So again, it looks like there's a selective effect that is occurring, pretty much mimicking the same thing that we had seen in reverse order in the order group. And again, if you put the whole group together, you will see the same pattern that I had shown you before, where the CSF is increased, but the hippocampal volumes are reduced, and that's basically the most striking finding. So, and that's the correlation for the whole group now, the memory unimpaired versus the memory impaired. And the correlation, again, is with the delayed memory, the different scores with regards to IQ. So, then putting this all together, we were interested in finding out what the incidence and degree of hippocampal pathology and memory impairment would be after exposure to neonatal hypoxia ischemia. As I mentioned, there were 123 patients and 65 controls. And at the severe end, 5% of them have got hippocampal pathology that ranges between 28 to 50%. So these 5% are actually amnesic. Next are the ones that have got moderate hippocampal pathology. That's more than 10%, but less than 25% volume reduction bilaterally. And the incidence is 16%. But then there's a huge component that actually does not have any significant pathology. That's less than 10%, and they don't really have memory problems. So that's what the breakdown looks like in terms of memory impairment, but there's only a one-to-one relationship at this lower end. So these 6 individuals are actually amnesic. But these 20 with moderate hippocampal pathology, there's more of them that has got memory impairment, but there's not a one-to-one relationship between memory impairment and degree of hippocampal pathology in the middle range. And of course, the memory unimpaired are approximately the same, 70%, and in relation to no significant pathology. So we wanted to then use this voxel-based morphometry to get a little bit more of a feel for what else is happened to the brains of these individuals, because, as I said, the etiology is varied in the sense that you can get hypoxia from different kind of conditions. And also, it affects the whole brain, so there must be more damage there than we can actually see from a neuroradiological point of view. So it must be more hidden damage. And the reason why I say that is because even though I have said that there is no measurable neurological impairment, and I don't know if you've heard of the name of Jean Accardi, but he's a very famous pediatric neurologist. And he literally could not believe that you could have this degree of hippocampal pathology, or you could have this degree of pathology in the brain without any manifestation that was motoric. So he came and he examined these patients, and in the end he was really surprised, but he had to do it for himself to be able to believe the data. But we told him that something interesting was going on, in the sense that when these children were younger, it wasn't their memory that was noted as being abnormal. It was actually their motor coordination. But their motor coordination was not such that it was a hemiplegia, but it was something on the softer side that they would be considered clumsy. And by the time they came to see us around the age of 13 or 14, most people actually compensate for their motor coordination problems. But we were thinking that if you look at the pattern of hypoxia ischemic damage that is reported in the literature, it's true that it's the hippocampus that takes the first knock. But after that, it's the basal ganglia that get it. So we were really searching for the basal ganglia damage that we couldn't see initially. And we're still having difficulty seeing it, of course, but at least we're getting a little bit closer to it. So we did the voxel-based morphometry on this large cohort of patients in relation to the normal controls, and of course the bilateral hippocampus showed up as being quite a robust finding. But then we also found that there was this bilateral thalamic damage, and it appeared to be more anterior, and of course that did make sense to us, because of course this is part of the hippocampal thalamic circuitry, so it is not surprising that there is damage there too. But we don't know really which is primary and which is secondary, or whether in fact they're independent or they're related, but it is the case that it is part of the circuit. So maybe if the hippocampus becomes damaged first, then the output actually affects the thalamus as well. And we also wondered whether this was because the patients actually had there were a lot of patients in the group, so maybe everybody was adding a little bit to result in this significant finding. But in fact, when we did it on 10 patients and matched controls, we got exactly the same pattern. So it's not the size of the sample, but it really is the a reliable finding that you've got the hippocampus and the thalamus as the two major sites of damage in these cases with hypoxia ischemia. So then we selected, this is the work of Anna Gencho, who's a PhD student. So she selected then the severe group, and now this has become our largest group of amnesic patients. So everybody in the severe group is amnesic. And then she also selected the moderate group, because now we wanted to see if you have severe damage to the hippocampus, what else do you have in the brain that becomes affected? And if you have moderate, what else becomes affected? And this is in relation to the normal controls that you can see. So the moderates are between 10 and 25% volume reduction bilateral. I have to keep on saying that this has to be bilateral, because if it's unilateral, you're not going to be amnesic. And you're not going to have memory impairment either. But if it's bilateral and it's within this range, then you are going to have amnesia. So this shows the comparison of these two groups, the controls in terms of their IQ and their MQ. So, sorry. So you can see that there's a 20-point discrepancy here, and there's a 32-point discrepancy here. So the severe group is definitely more impaired, both in terms of their hippocampal volume reduction and in terms of their memory function. And in terms of their global volume reduction, you can see that the white matter in the severe group is affected. So this is understandable because, obviously, as I said, the condition is such that affects the white matter as well as the gray matter. But in fact, if you look at the gray matter here in the severe group and in the moderate group in relation to controls, they're not significantly different. This is total gray matter, and then total white matter and CSF, where you do get the significant impairment in the case of the severe hippocampal atrophy. So now she looked at both gray matter and white matter abnormalities, shown, the gray matter shown in yellow and the white matter shown in pink. And for the gray matter, you can see that the hippocampus and the thalamus and the right putamen, now we're getting the basal ganglia coming in. In addition to the hippocampus and the thalamus, we get the right putamen and the right caudate nucleus, and this is significant density reduction in the severe group relative to the controls. In terms of white matter, we get the corpus callosum, the splenium of the corpus callosum, the fimbria, and the fornix. In terms of this reduction, the significant density reduction in the moderate group versus the normal controls, for gray matter, we just get the right hippocampus and the left thalamus, and we don't get any white matter reduction. So the morphometric abnormalities in these patients with severe hippocampal atrophy are all consistent with the pattern of hypoxic ischemic damage that has been reported in the literature. And the white matter density reductions in the fimbria and also in the fornix is possibly a reflection of the hippocampal atrophy, because that is, again, part of the circuit. And the reduction in the gray matter density in both patient groups does extend to the thalamus, and that's not surprising, again, because of the circuitry, but we're not absolutely clear as to whether this extrahippocampal damage that we have documented contributes in any way to the memory problem, or the memory problem is purely a hippocampal dependent phenomenon. So I'm not sure, I have a few more conclusions just to sort of bring all of the voxel-based morphometry findings together. The one about the right caudate nucleus and the putamen in the severe group probably contributed to the motor coordination problems that I was talking about. But whenever we try to measure motor coordination problems in the group at a later age, we fail. No matter what we do, they don't seem to be, none of our tests are sensitive enough to pick up this subtle abnormality that they have. And the things that are left that we don't understand, I mean, there are lots of things that we don't understand, We don't quite understand the significance of the splenium of the corpus callosum, but then it's very close to the retrosplenial cortex, and maybe that's a reflection of the retrosplenial cortex being yet another station in the circuitry that may have become affected. So putting all of this together brings me up to 7 o'clock, which I don't know, I've lost track of time because I don't know exactly when I started. And I know that I'm not at the end of my talk. Do I have a little bit more time? Because up to now, I've really looked at the weaknesses and the strengths at the first level, because these patients show 3 dissociations, and I've only covered the first one. So I can quickly go over the second one, which is the dissociation between recall versus recognition. So this was a study that another one of our PhD students, Anna Adlam, completed. And it had to do with the ability, the very impressive ability that they have to recognize things that they have previously seen before. And for those of you who may know this test of doors and people, that's been designed by Alan Badley and his colleagues. It's made up of 4 subtests, 2 for recognition, 1 verbal, 1 nonverbal, and 2 for recall, 1 verbal, 1 nonverbal. So the test of recognition, nonverbal, is a test of doors. So they see a list of doors, and then after there are 24 of them, they see 24 doors, and then there's multiple choice recognition of the door that they have seen. So they have to choose, having seen this among the list, then they're shown a list of 4 doors for each one of the items that they have seen before, and they have to choose the one. So you can see that what Alan Badley has done is that he's made the recognition tests extremely difficult so that they can become equated with recall, which is very easy. I mean, he's made it easy in this test. He's made recall easy, recognition hard, because naturally recognition is easy, recall is hard. So that's what he has done. And this is the verbal version of it. They see a name, and then they have to recognize it among these 4 choice alternatives. But this is a list, so it's quite difficult, actually. And for recall, they have to learn through a paired associate design the name and the face of 4 people. And the same design is for the nonverbal version, which is learning 4 shapes in a paired associate design. So when you give this test to our amnesic patients, this is the amnesic patients shown here in pink versus normal controls. There were 12 of them in each group. You can see that recognition is preserved. There's a disproportionate impairment in recall, which is consistent with what I was just showing you earlier on in terms of episodic semantic distinction. So it's held up here with recognition being preserved, recall being impaired. And then when you put the moderate group together with the amnesic group, so that you have a range of hippocampal pathology, as shown here, hippocampal volumes shown here, and the people test. This is the relationship between verbal recall and hippocampal volumes. So it's verbal recall and hippocampal volumes. You can see that there's a significant relationship here, with the severe end being down here, the moderates being further up. And if you do the same thing with visual recall, again you find this significant correlation with the severe end being here and the moderates being further up. But when you look at this relationship for recognition, you can see that in verbal recognition there is no significant correlation, nor is there a significant correlation in visual recognition. So recognition is not dependent on the hippocampus, whereas recall is. And Alan thought that maybe if we repeated something for recall, then maybe it would get in. So you could actually recall it after several repetitions. So another test was designed, and this was a test of videos. So videos were presented to the patients. Actually, this is John, just John himself, and his two controls. So the idea was that they would see this video, and they would immediately recall it. They would immediately recognize it or recall it. So there were two videos shown, one for recognition, one for recall. And one of the videos was shown only one time. Another one was 4 repetitions of it. And this was immediate, so immediate recognition of this video. And as you can see, I think John is actually pink. No, sorry, John is blue, because that's John here. So in relation to his two matched controls, you can see that in immediate recognition, John's performance is no different, nor is it different after 4 repetitions compared to his controls. However, then there was overnight sleep, and then he was tested again. The one that had 1 repetition, he had become significantly impaired relative to his controls, but the one with 4 repetitions, he was able to actually recognize. So in recognition, repetition helps. However, let's have a look at what happens with recall. The one that was shown one time, he was very bad at it at recall anyway, but with 4 repetitions, in the immediate condition, he actually did improve. But after sleeping, he went down again, with the 1 repetition practically to the same level, and with 4 repetitions, it still didn't help. So there is a fundamental problem that they cannot overcome, no matter what you do. Maybe 10 repetitions would have done it, but it's unlikely, because you can see that with the one presentation, he really goes down, but even with repetition, it just doesn't come up. So it's a very, very slow learning process that makes it accessible to recall. So this is the last part now. It's the dissociation between recollection and this sense of familiarity. And that one was done in several ways. One of them was this collaboration that we have with Emre Düzel, that is looking at the ERP signature associated with familiarity versus recollection. And I hope that I have put this, no, I'm sorry, I put this in the wrong place. First, I'm going to tell you the behavioral distinction between recollection and familiarity. And this was a study that we did with John Gardner. So a list of words are presented to John, and he has to decide whether he likes them. There has to be a levels of processing effect that we try and manipulate in order to get him to really pay attention and hopefully be able to recollect. And later on, he's given this recognition paradigm where he has to say whether he's seen the word before or not. He's seen the picture of the object before or not. It's a judgment that he has to give. So there are remember responses and there are no responses. It's a remember no judgment task. So as you can see, this is the responses of John in relation to his controls. So these are remember responses. These were items that were supposed to have been recollected. So there's a picture of an accordion. And the control, when they see the accordion, they say, they remember the thought process that was associated when looking at the picture of an accordion. They say it was a funny looking piano. When it comes to John, all he can say is that it was definitely there, I saw it. So his remember responses are very indistinct. And you have to remember that John doesn't really remember or doesn't really know what it's like to be able to recollect, because he's never recollected before in his life. So he doesn't even know the experience of it. So no matter what we try to explain to him, what it is to recollect something, what it is like to do mental time travel, he understands the words, but he doesn't know the experience of it because he's never been able to do it. So when you give him the picture of a peach, he says, I remember seeing the peach. But this is not very convincing, because somebody who really understands or recollects having seen something will remember the thought process, as this control does. who says, I thought I would like to be able to eat peach. But when it comes to the no responses, John is just like the controls. So his no responses are perfect. He responds on the basis of familiarity. He recognizes, but on the basis of familiarity. So this is something that we're trying to really get a handle on much better than this, because it's a very difficult concept to make them understand. So the other day we were doing some tests with John where we were looking at some incidental items as opposed to some items that really had to be recollected. And I started talking to him about what it was like not to be able to recollect. And every time that I asked him whether it was a problem, he kept on saying it's really not a big problem. So I said, you make it sound as though it's not a big problem to have this kind of an episodic memory difficulty. And he said, no, it does have its advantages. So I said, well, what are its advantages? He says, well, for one thing, I don't carry any grudges because I never remember who's done what to me. So that's actually a good thing. And then he said, so I said, well, what else? He said, well, I'm also very happy all the time. I don't get very upset. And I said, well, how come? And he said, well, because everything is around me is good. So I don't have to worry about things that are not good because it doesn't stay with me. And he says these things in such a logical way that you almost feel as though he's talking about somebody else, not himself. Because, you know, it's almost too intelligent to be saying these things. And yet it's true. So he says that he really doesn't feel as though he's missing anything because he's never had the experience of it. And I don't want to say the word ignorance, but in a sense, ignorance is bliss. If you've never had that problem, I mean, if you've never experienced it, you don't miss it. This is the study that I wanted to tell you about. It's the familiarity versus recollection that we did with Emra Duzel, which gives you the electrophysiological signature of this impairment in recollection that John has. So the test, again, was a test of word recognition, which later on they had to, John and the controls, had to do a remember no judgment on it. And the typical signature that's associated with this visual word recognition using the ERP paradigm, in the normal adults, you get this modulation in the early time window at N400, which is associated with recognition, with familiarity, and later on you get this modulation, the late positive component effect, that comes in within the 600 millisecond time window. And this is the normal pattern that you see in the adults. And this is the pattern that was seen in John, where you get the normal modulation for familiarity that comes in the early time window at the N400 effect, but the late positive component modulation is missing in John. And that is the scalp topographic distribution of this modulation effect. As you can see, in terms of the N400 effect, which is associated with familiarity, John shows the same effect as controls, but when it comes to the late positive component effect, it's missing in John compared to the controls. So, I have shown you 3 dissociations in these patients with developmental amnesia, a pattern of weakness and a pattern of strength, and a dissociation that goes 3 ways, and the deepest level really is the one that I've told you about last, which is the distinction between recollection and this sense of familiarity. And the neural substrates that results in this type of dissociation is, of course, this very selective hippocampal pathology with the relative preservation of the parahippocampal cortex. The opposite point of view to Larry Squire, but these are the data that we have. Larry interprets this in terms of plasticity of the developing brain, but although there is some degree of plasticity, you cannot deny that, but at the same time, it's really a reflection of the selectivity of the lesion and the fact that they have to develop, obviously, their memory ability in the presence of this bilateral hippocampal pathology that they cannot overcome. So where are we going with it now? We have a new program grant from the MRC, and the first thing is that we're actually looking at the third dissociation at a group level, and we've already gotten the data, and the paper is going to be coming out very soon. It's actually an MEG study of 17 of the memory impaired and developmental amnesic patients doing a item versus context association using the MEG paradigm, and that is going to be coming out. So now we have group effect showing exactly the same dissociation that I showed you in John. And then we have this new semantic learning, because we just don't understand how they learn. So we're trying to understand how in the presence of hippocampal pathology you can actually do semantic learning to the level that they can manage. So that's another experiment that's almost finished and hopefully we'll be writing up. Then we really want to understand this hippocampal thalamic circuitry a little bit better. So we're using DTI, and Marco, we're looking at all your papers. So we're looking at it, but I must tell you that it's confusing us because we find abnormality in many places. And we can't quite figure out how this is. I mean, on the one hand, it's understandable because of all the white matter problems that I've just demonstrated, particularly in the amnesic, the severe cases. But it doesn't seem to fit in, to fit properly, quite honestly. So we have a lot more work to do there. And then we're doing this prospective study with ischemic protection with tissue preconditioning. So this is what's going to be keeping us busy for the next 5 years. And I want to thank you for your attention and also acknowledge all my collaborators. Really, it would not have been possible if we did not have a huge group collaborating with us on the cognitive neuroscience side, but also radiology and physics, the neonatology unit who made patients available, the cardiac intensive care unit that made their patients available, and our collaborators, Mort Mishkin and Richard Saunders at NIH, with whom we've been doing a lot of this amnesia work. Thank you very much.
Any questions? Joe?
And you showed very evidently how explicit memory is related to the concentric network, how it is dissociated from implicit memory. I just wanted to know whether you had any ideas about as a circuitry of implicit memory.
Well, we are actually looking into that. First of all, I must tell you that we always start from behavior, because that's our guide into the circuit. And it does appear as though their skill learning is not that bad at all. And that goes along with the idea that really we have not been able to find very strong evidence of basal ganglia, particularly caudate and putamen abnormality. The problem is that implicit learning, I mean, we've tried several paradigms, but none of them, they're mostly motoric. We have one test that is based on Neil Burgess's task of boundaries and landmark, and we have to analyze the results, but we've actually got it on a very large group of amnesic patients and controls. And we're hopeful that the dissociation will hold up, but it's a very difficult one to actually get a handle on, I must say. A lot of it has to do with the fact that it's skill-based. And to do proper skill learning, you really need a lot of time and a lot of building up of the skill. But I'm sure that a lot of the things that we think are cognitive, or we used to think that is cognitive, really looks like it's skill-based, and that's how they learn it. I know this sacrilegious to say this to people who are studying language, for example, to say that language is a skill. But quite honestly, that's how it seems. And because that system is okay, because we have another group that has got damage in that system, and my God, they have difficulty. They don't have any difficulty with memory, but they do have difficulty with skill. So we do have that dissociation by comparing these two different patient groups. But it's very difficult to zero in on one domain and say, oh, this is part of the implicit memory system. So we haven't been able to make the story as attractive as the hippocampal story.
I wanted to ask you something about language. So, are you trying to see, for example, whether you allow them to verbalize and maybe versus non-verbalizing, whether that improves, bringing in some verbal working memory components when they do the task?
I didn't say anything about their working memory, but their working memory is absolutely fine.
It's fine.
Absolutely fine. They do present, in normal circumstances, they do present as though they're a little bit frontal. But it's because it's their memory that's failing them that they behave in this way. They may lose track of their conversation, for example. The mechanics of language is absolutely perfect. There's really nothing wrong with it at all. Their mentation expressed through language is absolutely fine. They may lose control over what they're saying so that they lose track of the thread of thought, but that's because their memory fails them. I don't think they're frontal. Because, we've done, for example, a test, this Michael Petrucci's self-ordered pointing task. We've done that task with them, and they have no problems with self-ordered pointing, generating the response. But when the array becomes long, so that you have to remember what you have touched, that's when they start showing the problem. Again, it's a memory problem. It's not an executive function deficit. So, the contrast between the KE family members and the amnesic patients is actually a very interesting one, because of course they have all the problems with the skill of motor output, but no memory problem. And the reverse is true of the amnesic patients. So we're learning a lot by comparing these two systems together.
I just have a question about the dissociation you mentioned briefly about the hippocampal function versus the parahippocampal cortex, and how that might be somewhat maybe preserving some function of memory. Is that something that might result from plasticity, or is that potentially what separates them from adult amnesic patients?
If you ask this question from Mort Mishkin, he will say absolutely. He will say that, he will say that what you're seeing is the preservation of the parahippocampal cortex that's allowing them to do as well as they're doing in terms of their semantic memory. It's got nothing to do with plasticity. It's because the tissue is doing its job. But I actually think, to tell you the truth, that plasticity is at work. Because I have never seen, we don't work with adult patients, but generally speaking, from the ones that I have read their case histories very well, I feel as though their problem is much more to do with having lost a system that used to work and they cannot adjust to it. These children have never had a system that didn't work. That worked properly. So they didn't have to make that adjustment. They just compensated for whatever it was that they were missing, not even knowing what they were compensating for, because life demanded it of them somehow. And you get instances of this. For example, when we give them a test, I don't know if you're familiar with this list learning test. When we give them lists of words to learn and we get it back from them, and a late adult amnesic patient will say they cannot remember. They will tell you, they will give you 2 words and then they'll stop. They'll give you 2 words in the most recently heard words, and then they'll stop. But these children will continue saying it, even though they're saying something wrong. But nevertheless, they keep on adding words, even words that were not on the list. because they will never say, I can't remember. And this is actually very interesting, because this is partly the reason why John says, I'm very happy. He doesn't think that he's got a problem. Whereas the adult patient with amnesia really knows that they've got a problem, because their memory wasn't like that before. So that adds a lot to the ability to be able to compensate and to be able to get on with life. And it's really a pleasure to work with them. The only insight that we have that this is really related to some degree of plasticity is that the late cases, we have one who was 15, and he suffered a very severe hypoglycemic episode in sleep, and he woke up and he had become amnesic. He was a musician, and the first couple of years after this incident, he was between the ages of 15 and 17, he was actually very, very depressed and very upset and very agitated because he had lost his memory. But now that he's 26 years old, he's actually gotten used to it. He's no longer depressed. He tells you that he's got a bad memory. But I'm sure that he doesn't even remember what his relatively good memory was like before he had that episode. And in the same way, his parents don't remember. Because don't forget that at the age of 15, you're still young. And people are still looking after you. So you adjust to the deficits that you have. It's not the same story as an older person suddenly becoming disabled. These individuals don't consider themselves disabled. And that's one of the reasons why they don't come to medical attention.
Thanks for a great talk. It follows on really from the last question. I was just wondering about the issue of compensation and the surrounding, the structures that surround the hippocampus. I mean, have you looked at things like flexibility and recall and clustering and that kind of thing, which might give you some clue as to whether what they remember is kind of fairly inflexible and fixed, or whether it's more fluid like you would expect from something.
Yeah, you know, it is really the case that you almost feel as though the hippocampus is very precise. It has to be very precise. It has to be picking things up one time. You don't have to repeat it. It's just there. And their memory doesn't work like that. It really is quite, the categories, the boundaries for categories of things to be remembered are very fuzzy. So you can easily mislead them into thinking that something has happened when in fact it hasn't happened. So they're prime candidates for false memories. You can mold their memories to become what you want it to become, and that's why they're very vulnerable. So somebody who wants to take advantage of them can easily do so because their memories are not precise enough to be able to guide them through life. So in these ways, you can tell what's failing them. It's not that they don't have, for example, I remember John, when Princess Diana had died, we were asking him a lot of questions about what he remembered about the incident. And he kept on giving us such good answers that we thought, my goodness, he must remember, because it sounded so logical, everything that he said. When were you when you heard the news? He would say that, you know, I saw it on television. Well, I mean, of course, it sounded quite reasonable. But then when we went and checked every single answer that he had given, we realized that it was close, but it was not correct. He had not seen it on television. His mother had gone to his bedroom and had woken him up and told him that, but he didn't remember that. What he did remember is having seen it over and over again on television. And he just made the story up because this is the logical thing to do. And in this respect, I know that we've got papers with Eleanor Maguire on imagination in these children, and their imagination is actually good. But when you've got a good semantic representation of the world, you're not going to be able to, you're not going to be caught making up a story that doesn't fit. It's going to be mapping on to what you know of the world. And their semantic memory is good. So their imagination is good because they imagine things that are based on their semantic experience of the world. doesn't mean that they can remember it, or it doesn't mean that they travel in time to imagine it. They use their somatic memory to create a story. But that's not forward mental time travel. And in fact, if you ask John about mental time travel, he can give you a perfect example of it in terms of time machines, but not in terms of the experience of traveling in time in your mind. That he cannot do. But he tells you everything about time machines, how they can go back and forth and back and forth. So it's all very theoretical, not relevant.
It's false memory. It reminds me that when you have a corpus of patients, it's that confabulates is the connection between the dorsal medial nucleus and all the frontal cortex that are damaged.
Yeah.
And that would fit with your findings that,
Exactly.
that you have that. Maybe the mammillary bodies are too small to be seen. Have you tried, for example, to have
No.
high resolution?
Yeah, absolutely. Actually, they're not too bad. On 4 to 5 slices, you can catch them. And so far, again, this is the work of Anya, because she's doing the thalamic parcellation.
Yeah.
She's also doing mammillary bodies. And so far, the amnesic patients either have no mammillary bodies, it has atrophied, or they have very little ones left. So, you know, the whole circuit is really lighting up, or failing to light up, whichever way. But it's very difficult to say what part of it is doing what. It seems to be that the primary knock is the hippocampus, but then the other ones become involved as well.
Just drawing off from what you were speaking about. I work with Karen Scientist group at the IP, work with adults who were born very premature, and they did an fMRI task of vertebrate associates learning 2 years ago. And what they found was they had reduced bilateral hippocampi, but the parahippocampal gyrus was larger compared to controls, and they actually activated a little more compared to controls. So it's quite, seems to be quite interesting considering your baby and teenage stage. So I also wanted to just ask quickly, you showed the correlations between the patients, the severe and the moderate patients, and the hippocampal volume. I guess you didn't find, there was no correlation between task performance or memory and hippocampus volume controls.
No, there was not.
Yeah.
No.
No, good.
Yes.
Yeah, the makes sense. It's just something that we
Yeah.
identified.
There is no correlation in the
So
controls.
it's like there's like a point in hippocampus volume below which, if you pass that, memory
Exactly.
increases. But
Exactly.
there's probably some sort of threshold, whereas it is presumably a normal range, and anywhere in that, an increase isn't going to help you in your memory.
Yeah. In terms of a threshold, we really looked hard to find a threshold that we could say, beyond this point, you have the problem, and after that you don't. And it is true that if you go to the extreme end, we have never seen anybody who is not amnesic, who's got more than 30% volume reduction bilaterally. We've never seen that. And we've seen by now about 30 patients like this. So we think that we're on safe grounds. But it's the transition from that point gradually into the field, into the normality, that becomes problematic. In fact, I meant to put a slide in because we put all of the all of the amnesic, memory impaired, and the controls together. And it's a very interesting slide when you put all of them together and look at them like that, because if you imagine a zero line here, so the hippocampal volumes go like this, and then they become like that, and then they go like this. So you really get this sort of feeling that it's a continuum. And it's hard to, in the middle of the continuum, you just don't feel comfortable. You don't know where to put the boundaries.
It didn't seem
So-
like it was more higher, a higher correlation for the severe patients than the moderate patients, right? So presumably some of those moderate patients are kind of at the boundary.
Yes, they are, but we really don't feel comfortable calling them amnesic. So, you know, I said above 30% bilateral volume reduction. What do you get when you're 28%? Is 2% making the difference? Well, it really is gradual. So if the hippocampus had to pick up something one time very fast, the 28% would also fail. But if the hippocampus had the chance to sort of see it twice, the 28% probably wouldn't, but the 30% and above would. But it makes you feel very uncomfortable to put a boundary then and say, beyond this, you're amnesic, and below that, you're not. So,
Maybe you should have used taxi drivers.
yes, yes.
See the video.
And it seems from what you said that their experience is based on repeated events rather than significance. Do they show, do they tend to follow routines in everyday life or initiatives?
Absolutely. When you ask John, because he's actually doing quite well, so you ask him, because he was saying he doesn't have a memory problem really, when I was talking to him, or he was saying that it's not that bad. When you ask him, why is it not that bad? How is it that it's not? He said, my life is very structured. I know exactly. His life is very small. He only does a few things, you know. And his parents live very close to him. They check on him just about every day. The work environment that he goes to part-time is very controlled. So he moves within a very small area. And if your life is structured like that, which is the life of a child, because, you know, this is why, another reason why their problems don't become manifest until they become a little bit older. Because from a 7 or 8 or 9-year-old, you have certain expectations. But from a 4 or 5-year-old, you don't. You've managed their life. And then when they become teenagers, they're supposed to be able to get around by themselves. They're supposed to be able to remember to take their belongings with them. And, you know, they must remember messages and that sort of thing. That's when they start really failing, and parents start all of a sudden becoming worried as to, oh, where did this come from? But it had always been there. It's just that it was not challenged. And it's not just life circumstances. It's also the fact that the hippocampus appears to be growing. Because in the normal controls, when we do hippocampal volumes, because we have a huge range in age, the normal controls actually show a significant growth in the hippocampus, in the volume of the hippocampus. Amnesic patients don't. They are straight. So that's another sort of interesting thing. It's not just function and lack of opportunity to demonstrate that function, but it's also the fact that the maturity of the hippocampus is compromised as a result of this hypoxic episode.
I think we can continue on there. Just want to thank you again. We couldn't have a better representative of this approach. Thank you. I'm very glad you gave this talk. Thank you very much.
One more round, but drinks and the food.
So many questions actually. Ask the stories.
And